West? I don't remember. I thought there was another one around here. Besides Lutheran. Yeah. St. Luke's up in Milwaukee has one of the largest ones in the Midwest. I think holds 24 to 27 people. It's huge. But yeah, making sure you're taking these. Obviously, you're not going to take a patient all the way to Lutheran. You're going to bring them to St. Francis and they'll transfer them. Someone with altered mental status. Again, we have to ask, why are they unconscious? Gone are the days where we gave them a coma cocktail, an Amphidy 50, 100 of thiamine, and 2 of Narcan, and we hoped that one of those woke them up. But we never knew which one it was until we started doing the assessment later. Now we assess, do glucose reading. Are they hypoglycemic? Is it someone who's overdosed on drugs? What's their pupils like? Have they had, did they just pass out from alcohol? Do they have a stroke? When were they last seen normal? Making sure that you're providing the proper care for them based on what you see. Asthma, COPD, we were talking before. If you look, routine, albuterol or duoneb, and then just albuterol and then epi. Remember, these are basically guidelines. You can do and ask for things earlier if necessary without having to go through all of this, if you feel you have someone who is critical enough to do it. If you have someone with COPD and you think they would benefit from CPAP, going ahead and open up the bronchioles and giving medication to force it deep down into the lungs to help make breathing easier. Our pulmonary edema protocol, if they're stable, blood pressure, most of the time these patients are going to have extremely high blood pressures. But giving them the nitro, at least, or giving them it 3 times, using your CPAP device. But remember, nitro can drop preload, and so can your CPAP can drop your preload. Always want to make sure we're assessing our vital signs. Patients who were using CPAP for COPD, the max PEEP we want to get to is 5. Patients with pulmonary edema, the max PEEP we want to get to is 10 if we can. But we can titrate that. We can work our way up to it if necessary, if a patient is having a hard time tolerating it. If the patient's unstable, blood pressure's low, altered mental status, then we're going to go ahead and use our cardiogenic shock protocol. There was actually just a really good article that came out because dopamine's becoming a real issue for a lot of patients, and it's called push-dose epinephrine for patients with cardiogenic shock or patients with sepsis for helping raise blood pressure. So it's a really good article if you're interested. So we talked about some of the medications. Albuterol, dose is 2.5 milligrams. We give that in a handheld nebulator. It is a beta-2 adrenergic agent. It causes or it decreases bronchospasms, bronchodilation.
EMS 5 ambulance 21, engine 25, 25, 20, road point, all in the state. On a road 201, 89-year-old male, possible stroke. EMS 5 ambulance 21, engine 25, 25, 20, road point, all in the state. Road 201, 89-year-old male, possible stroke. 21, that's good.
You can come back and turn that in later, please. Sorry.
Oh, no problem. So our albuterol, again, we'll use it for someone with bronchospasms, bronchoconstriction, provides bronchodilation, decreases our bronchospasms. Onset, usually pretty quick. I thought the duration that he put up there was a little long. I didn't think it was that long, but it could, and I didn't follow up. But some of the signs and symptoms that you might see from it, someone's going to be tachycardic. They might have a slight headache from it. They may feel really on edge or shaky. Atrovent, our dose is 0.5 milligrams. right along with the mixture of the albuterol. It's going to be in a neb. We use it for bronchospasms, drying up secretions, and it's an anticholinergic medication. Down here, contraindications, take that out. I didn't get a chance when I was reviewing this. It is no longer a contraindication if someone has a peanut allergy to use it. That's been disproved and old for, God, when did we look that up? That was
07,
years, yeah, it's been a long time. Steve had a big fit about it in CE back years and years and years ago and had to be a pain in the butt. Yeah, it was you. You brought up the whole peanut thing at Beach Park. Stir in the pot. Yeah. The other thing too with this is that it does go ahead and help relax smooth muscles. We can use it up to 2 times now. Lasts a little bit longer. Don't forget about your inline nebulizer. Your inline nebulizer can be used on a bag valve mask, it can be used on the King, it can be used on an ET tube. So, and the eye gel too, it can be used on if we need to. You can bag in that albuterol treatment.
Bag it.
LASIK loop diuretic works in the loop Henley in the kidneys and the nephrons. We go ahead and use that for patients who we believe have rails. But again, you don't want to give it to patients who you think might be dehydrated. Takes a while to go ahead and start working. I think this will probably be one of the medications that truly is going to go off of our protocols with this next rewrite. It does cause some venodilation in patients with pulmonary edema, which is why it's been used, but most of the time we use it for diaphoresis, and that takes a little bit longer. Narcan, opiate antagonist, again, using Narcan, you always want to go ahead and give them just enough to make the respiratory rate go up. Don't forget too, if someone's been breathing 4 times a minute, they're probably metabolically or respiratory acidotic. Ventilate them a little bit before you start pushing Narcan, because Narcan can cause non-cardiogenic pulmonary edema, and that's the last thing you want to do for these patients. If you push it too fast, push it too much, withdrawals, vomiting, seizures are all different side effects that can be a cause of it. Racemic epi, we don't have racemic epi, I call it ghetto epi, we nebulize the epi, and that's why I said go ahead and look at your chart to see what your concentration and your mixes are for it. But racemic epi can be used, it's adrenergic, it has both alpha and beta effects. Remember with our alpha effects, it will go ahead and stimulate the heart, cause vasoconstriction, whereas the beta 2 effects cause some bronchodilation, helps dry up secretions, reduces bronchospasms. And that's it. Anybody have any questions? You want to turn that off?
Yes, ma'am.
Thank you. Before someone says something.
One more time.
One more.